Let's get started. Okay, good afternoon, everyone, and welcome to today's Grand Rounds presentation. It's my pleasure to introduce our speaker, Dr. Jared Ruchensky. Dr. Ruchensky obtained his PhD in clinical psychology from Texas A&M University and completed his predoctoral internship at Massachusetts General Hospital and Harvard Medical School. Dr. Ruchensky's body of work addresses models and measures of psychopathic personality disorder or psychopathy, the utility of broadband personality assessment instruments, and dimensional models of personality pathology, which will be the center of his topic the center topic of his presentation today. He is especially interested in studying these topics in criminal, legal, and underserved, for example, LGBTQ plus populations. His work has been recognized with the John E. Exner Award from the Society of Personality Assessment, and he currently serves as an associate editor of Assessment, which is one of our flagship journals in this field. He is also an active clinician who routinely completes forensic evaluations and trains doctoral students in therapy and assessment. I'll add that he is a professor at Loyola University of Chicago, and he joined their faculty recently after serving as a faculty member at Sam Houston State University. We can see the title of his presentation, Dimensional Personality Pathology, Clinical Implications of Moving Beyond Categorical Diagnosis. And one of the things I'm looking forward to hearing is this discussion of the alternate model of personality disorders, as described in the DSM-5-TR, and thus putting us a bit on the cutting edge or leading edge of personality diagnosis. Dr. Ruchensky, on behalf of the department, thank you for taking the time to speak to us, and I will hand over the Zoom podium to you.
All right. Well, thank you for that introduction and thank you for having me here. I'm really excited to talk to you. I've planned to talk for about 45, 50 minutes, and so we'll leave kind of the last 10 minutes or so for questions, and I'll just kind of hop right in. Just this is my disclosure. I've done some paid consultant work for PAR Inc., which is the publisher of the PAI, but I do not receive royalties, and I have no other conflicts of interest to report. All right, so this is kind of an overview of what we'll be talking about today. So I'll talk a little bit about what I mean when I say a categorical model of PD, in case that's unfamiliar, versus sort of a more dimensional approach to thinking about personality pathology, presentation, and assessment. I'll cover the alternative model for personality disorders, which has become kind of the focal model for personality scientists, at least within North America for sure. And then we will walk through kind of a case conceptualization using kind of the traditional categorical approach to PD as well as the alternative model. The idea being that it should give you some sense of kind of how you might think about the same person using multiple perspectives. And then I'll kind of end with some overall takeaways and some tips or ideas about how you might start thinking about integrating the AMPD into kind of your regular applied practice, as well as some cautions surrounding its use. All right, so when I talk about a categorical approach to PD diagnosis and assessment, I am really talking about the model that all of us were trained on. It's the idea that when somebody comes into your office or you go to a prison or wherever you're working, you're meeting with somebody, you're trying to identify whether they have the presence or absence of symptoms listed within the DSM, and then if they have the correct number, correct kind of symptoms, they get a particular diagnostic or categorical label attached to them. So I have kind of a classic example here that I imagine most of us are familiar with, which is antisocial PD. So if you're evaluating somebody for antisocial PD, then to get this kind of categorical diagnostic label, they need to have at least three or more of these seven symptoms. If you have two symptoms, you don't get this label. So this is what I mean when I'm talking about kind of a categorical approach to PD. It's really just the traditional kind of medical model approach to thinking about personality disorder presentation. All right, I want to start with a couple of quotes. This one's from a paper that's increasingly, I've used this quote for a number of years, and we're almost at the 10-year mark for this paper. so I'll just read this to you. There is no evidence supporting the hypotheses that personality disorders are categorical or that there are 10 or more discrete types of personality disorders. This comes from an article in 2018 led by Chris Hopwood with a collection of authors from uh, the PD world and kind of beyond. The idea that PDs are not best represented by categories is kind of a long-standing idea amongst personality scientists. Although the alternative model is kind of revolutionary in a sense, it's really built off of decades of research and theorizing and evidence suggesting that the idea that you can kind of place people into these personality boxes just doesn't really work, and it doesn't really fit the data that we work with. So when we subject PD data to factor analysis, taxometric analyses, where we're trying to identify classes of people, like these are the psychopaths, these are the non-psychopaths, we just fail to recover 10 categories or classes of people, so to speak. This is from a paper that came out about a week and a half ago. It came out in JAMA Psychiatry. I view the DSM as an important paper plane held together by screws, matches, and chewing gum, added by very thoughtful clinicians and scholars over many decades to keep it flying. But DSM categories are largely based on superficial resemblance and necessarily limited. Within the PD world, the idea that PDs are best represented by dimensional constructs isn't new at all. And this kind of conversation about, what is the appropriate dimensional model within PD land is happening within a broader backdrop within psychopathology science. So we're going to talk about the alternative model today, which is specific to personality disorders. But if you're interested, you can, kind of Google Scholar the high top model. There's an increasing push to think about all of psychopathology and personality as kind of dimensional constructs that we all kind of fall along, so to speak. And so this has kind of been a revolutionary approach to thinking about PDs and psychopathology in general. I think kind of classically, when you think about research labs and how they've been kind of developed over the years, traditionally, you'll have kind of like, narcissism PD labs over here. You have the psychopathy labs over here. You have antisocial PD labs. You have borderline PD labs. And so we have kind of historically had this kind of separation of labs and research built around kind of an artificial diagnostic system that doesn't really hold up to empirical scrutiny. So I want to talk a little bit about some of the limitations to the categorical approach to thinking about personality disorders. This comes from a few different papers surveying the literature and thinking about some problems with the application of a categorical model. One that stands out is sort of limited reliability, the idea that, depending on who you're being evaluated by, you might get a different diagnostic label. So the inter-rater reliability or the agreement across evaluators is not particularly compelling when we look at the empirical research on that. Pretty commonly, patients qualify for more than one PD diagnosis. So if you have one PD diagnosis, you probably also qualify for at least one other diagnosis. I think a lot about sometimes when I've done applied work where patient presentation is more severe and complex, and I'm looking through like records to see which diagnostic labels have been applied or removed for folks over the years. I feel like sometimes I'm looking at kind of like this like CVS receipt of diagnoses that have been added or removed or changed or modified. And it sort of undercuts the utility of this categorical model. The idea is that if you could, bin people into this particular category, it conveys some kind of clinical information about their presentation and what you can kind of expect them to present like in the room. But if you have somebody who's in their file, they're getting 3 different discrete diagnostic categories, it kind of undermines the idea that these categories are discrete when in reality, when you apply them to real humans, they don't really present as discrete. There's pretty overwhelming evidence that personality pathology is dimensional. At this stage, amongst personality scientists, we're not really having conversations anymore about whether we should think about PDs are dimensional or not. We're all pretty much in agreement that PDs are dimensional. Most of the debates and arguments nowadays really center on like, Is the alternative model sufficiently comprehensive? Are we missing pieces of information, moving from a categorical model to the dimensional model? Are our measures working as, we think they should be working? But we're not really debating whether personality disorders are categorical or dimensional. We have pretty much as a field kind of fallen behind the idea that they are dimensional. I've talked about this a little bit, or hinted at least. The cutoffs that exist within categorical approaches to PD are arbitrary. So, like antisocial PD, you need 3 of 7 to get that categorical label, but there's no like empirical or scientific justification for 3 instead of 2, instead of 4, instead of 5. And even when you think about assigning people a symptom or not, there's not like a clear empirical divider between you have this symptom or you don't have this symptom. You certainly work with folks where you go, they certainly have that symptom, but a lot of folks that you'll work with could potentially go kind of either way on these symptoms. And then I've kind of hinted at this already too, that the sort of artificial separation of these PDs into these discrete boxes kind of silos our research in ways that are probably an inefficient allocation of time, energy, resources, and work. And it also creates kind of this disjointed literature that makes it more challenging to kind of like integrate findings across disorders, so to speak. And so one of the things that I think has really benefited the field is this shift to we're all kind of studying dimensional models of personality pathology nowadays. And so we've kind of pooled all of our science, so to speak, all of our resources behind studying this one model as opposed to having sort of, separate researchers studying separate diagnostic labels or separate diagnostic categories. All right, so let me talk to you a little bit about the alternative model for personality disorders, the AMPD. This is in section 3 of the DSM. So if you have a DSM, you can flip to the back of the book and it's already there. When I talk to folks, some people are surprised that it's there. They have no idea it's there. And other folks, they, have looked at it and gone, "Oh, that looks like it's emerging. I'm not going to read much further beyond that." But you have access to this model if you have a DSM. So this is the first component I want to talk about, which is personality impairment or personality functioning. So we tend to think about criterion A as kind of a severity marker, so to speak. So higher degrees of severity convey kind of like higher levels of problems attached to somebody's personality presentation. So you can think about criterion A as this severity marker that helps you think potentially about things like the level of care this person needs. We also kind of think about it as kind of this like non-specific marker of problems. It's kind of this general problem factor where if you just are kind of higher on this severity dimension, you're more likely going to have problems popping up across different life domains or areas of your life. So think about personality impairment as being comprised of these 4 elements. These are not 4 distinct factors or 4 distinct scales. These are 4 elements of one thing. So think about elements reflecting self-functioning, so your ability to create a coherent sense of this is who I am, a coherent sense of this is where I want to go in life, this is where I kind of envision myself going in life. And then interpersonal functioning, which has to do with your ability to kind of develop and cultivate mutual, healthy, two-way kind of relationships with some degree of emotional and social depth attached to them. And so again, we think about criterion A as this sort of severity marker of how bad is it, how bad are the problems attached to this person's personality presentation. We tend to kind of think about this as kind of like the core of personality disorders. We tend to also think about personality functioning as kind of a dynamic construct. So you can certainly think about somebody as having kind of higher typical levels of severity or lower typical levels of severity across time. But we do think that criterion A is particularly sensitive to environmental and interpersonal cues. So these personality traits that I'll talk about in a second are relatively stable, whereas personality functioning is more of a dynamic, changeable construct that might change as a function of events that are happening in your day-to-day or moment to moment. All right, so the next component that I want to talk about is the pathological trait model. If you remember back from undergrad days, the five-factor model, Ocean, if that rings a bell, this is going to feel very, very familiar to you. This is kind of like a pathological variant of the Big Five or the five-factor model. Most of these domains and traits have some degree of correspondence with models of normal personality. So, for example, negative affectivity is one of the higher order domains, and I've listed a couple of the lower order facets that belong to negative affectivity, but we tend to think about somebody who's higher negative affectivity as being more prone to intense mood fluctuations, greater proneness to feeling bad or experiencing unpleasant affect. Detachment has to do with sort of somebody's interest in building connections to other people. So somebody really high in detachment would be somebody who's just like really disinterested in other people. They don't really have much of an investment or want to build meaningful long-term connections with people. We have antagonism. Antagonism is sort of an interpersonally exploitative approach to relationships with others. People who are higher in antagonism, thinking about them in terms of like higher in manipulativeness, more remorseless, more callous, more grandiose. And then disinhibition, which has to do with poor impulse control and is kind of analogous to low conscientiousness from the five-factor model. So these four have pretty clear corresponding traits within the five-factor model. The one that diverges the most from models of normal personality is psychoticism. So we tend to think about the psychoticism domain as capturing kind of the odd or eccentric or unusual kind of presentation that sometimes accompanies folks with personality pathology. All right, so I've talked about these two components as though they are like separate and separable. From an empirical perspective, they're not. There's a lot of redundancy in these two components, but from a clinical perspective, they do serve different functions. So if you look at the empirical literature pretty consistently points to a lot of conceptual and empirical overlap across these two, but clinically they serve two very different um, functions here. So you think about criterion A as kind of the like problem indicator, so to speak, the kinds of problems that somebody might have, whereas criterion B is more about sort of like the flavor of that presentation. So, somebody could have interpersonal impairment, so that's criterion A, but the flavor of that presentation might look quite different. So somebody might struggle to build or maintain long-term interpersonal connections because they're high in detachment, so they're just like not really interested in people, or potentially because they're really high in antagonism. They like exploiting people and they have a propensity for hurting other people and not feeling bad when they hurt other people. So we tend to think about these as kind of showing up together, with criterion A being kind of the severity, the impairment marker, whereas criterion B is sort of the like what flavor, what presentation is that impairment going to look like kind of in the room, so to speak. All right, so I said this was sort of like a dimensional model, which it is, but it's a hybrid dimensional categorical model. So the research is pretty clear that there aren't categorical diagnoses for PD in the wild, that in nature there aren't really like these joints you can carve, so to speak. Within the alternative model, you can still overlay categorical diagnoses on top of these dimensional constructs. For all of these traits, for all of these elements of personality impairment, we all kind of fall along the continuum here for impairment as well as these trait presentations. And if somebody has elevated levels of impairment and elevated levels of these pathological traits, you can still apply a diagnostic label to them if that is useful to you. Again, this wasn't built in because it was based on some sort of empirical literature. It's more or less kind of acknowledging the reality in that the systems that we operate within rely on these categories. So insurance companies really like diagnostic labels. So a lot of the systems that we interface with as healthcare professionals rely on some sort of like diagnostic label. So these are quite useful for those kinds of purposes, but I wouldn't necessarily think about them as useful necessarily in terms of empirically backed ways of thinking about patient presentation. One other thing I want to highlight too is that The AMPD is kind of a reshuffling of personality pathology information. So even if the alternative model is entirely new to you, this is the first day you ever heard about or thought about this model, you've probably thought about these constructs before, whether you're using sort of like the categorical diagnostic language, or just kind of like everyday colloquial speech. We all kind of think about folks as, that person's has pretty poor impulse control. That person's pretty mean. That person is pretty emotionally reactive to situational cues or situational contexts. And so when I've taught folks this model in the past, it feels a little unwieldy at first because there's kind of a lot of pieces to it. But what I find over time is that once folks start using this model, once the trainees I work with start using this model, it feels pretty intuitive. And it feels kind of like a more nuanced and less clunky approach to thinking about patient presentation relative to the categorical approach to personality disorders. So, don't think about this as necessarily like we're ejecting the categorical model in entirety. We're sort of reshuffling this around in a way that better fits the data that we have. All right, so let's walk through a case conceptualization piece. This is an amalgamation of fictional details as well as some folks that I've worked with over the years. And so I want us to think about this person from both a categorical lens as well as an alternative model lens. And we'll start with the categorical lens, which I think folks will be relatively familiar with, and then talk about how we can think about him from a more dimensional perspective. So in this sort of scenario, let's say that you are doing evaluations for a probation office. So you are completing court-mandated psychological evaluations, and you often get folks being referred to you who are convicted of intimate partner violence of some form. And so this psych eval is sort of a required part of their probation. And these folks are often required to attend anger management groups as well as domestic violence groups. So we have Todd here. Todd is a 27-year-old cisgender heterosexual white male reporting mood swings, depressed affect, and difficulties with others. So in terms of his index offense, he was convicted for family assault. The context of this is that he was living in an apartment complex with his, at the time, wife. His neighbors heard like a very loud crash, a very audible like scream, indicating like panic and fear. Called 911. And they showed up and essentially broke up a Todd hurting his spouse. From the police records, it indicates that Todd was high at the time, so he'd been using cocaine, and that was sort of like a proximal factor for the instigation of violence. The violence included punching his spouse, throwing objects, things from Kleenex boxes to plates. His wife was treated for non-life-threatening injuries. There were some pretty clear bruises, pretty clear bleeding, but she wasn't in any, there wasn't concern about her life after a result of this altercation after Todd's abuse towards her. But she did report like being afraid for her life and being concerned that if law enforcement hadn't intervened, that things might have escalated and she may not be there. All right, so in terms of some life context for Todd, so he and his wife are no longer together. They're in the process of being separated. She has a restraining order against him. He describes their relationship as his relationship with her as being pretty off and on. They dated, broke up, had very intense fights, had very intense reunions. He feels a degree of sort of like tension or discomfort surrounding his current legal circumstances, and that he says like, I still love her, as well as some minimization of the seriousness of his violence and assaults towards her. He completed high school, spent about a year and a half in college. He was interested in engineering, but had a habit of not showing up to classes and did not do particularly well in college. His employment history is pretty scattered. He has a habit of picking up jobs, retail jobs, and leaving them, either because he gets bored and just says, "I'm out of there. This is too boring for me," or he feels like the job and the people he is with are beneath him. So it kind of blends together at times. He says this work is boring because I'm bored, and I can do better than this. But at the same time, he also hasn't really sought out opportunities or successfully sustained pursuit of opportunities that would place him to be in a higher position, at least in his mind. He has a few longstanding friends, so his friend group is primarily comprised of folks from high school. They stopped talking to him after this recent arrest. He conveyed sort of like they've all kind of partied together over the years. Other friends of his have substance abuse related charges, DWIs. I think one of them had like an assault charge too, related to like a bar fight or something along those lines. But they apparently have kind of dropped him after he got convicted of the family assault charge. So he reports being raised primarily by his biological father alongside two younger sisters. His mother had substance abuse issues related to alcohol as well as heroin and cocaine, and he suspected but never confirmed methamphetamine. So she had charges and convictions related to distribution as well as use. And he also talked about when he was a kid, he used to run away a lot, but that sort of stopped in high school after he sort of created this friend group that has recently kind of abandoned him. He denied sexual abuse. He sort of said that there was potentially some physical abuse in the home. So his father used corporal punishment. He said that some of the abuse kind of went beyond what was culturally normative for where he was living. That, his father would start with spanking, and it would sometimes, when he got really irritated or mad, would turn into beatings. And so he wasn't quite sure what to make of that. He has a pretty storied history of getting in trouble at school. Got expelled at age 9. I think my memory of this one is that like he went after another kid with scissors or something along those lines, but he like made a pretty serious threat towards another kid that got him kicked out. And he was sent to a school for kids with conduct problems. And so he got some kind of early intervention, so to speak. When he returned to typical school placements. He sort of enjoyed the socializing aspects of it, so he liked interacting with other people, but found school to be kind of like hit or miss, is what he used. I get bored sometimes with some subjects, other subjects are fine. Sometimes I hate my teachers, sometimes they're good. And then he got suspended in high school for he and his friends set off fireworks at a homecoming game, and it basically like stopped the whole game, understandably. So he admits to a pretty long history of substance use issues, particularly centered around alcohol and cocaine use. His first drink, he endorsed drinking, I think it was like shots of vodka as like a 11-year-old kid. He just sort of like snuck into his dad's alcohol cabinet, and I think he went to like a park or something, and he and his friends were drinking. And he endorsed experimenting with marijuana and cocaine kind of throughout junior and high school. He mentioned some degree of other substance use, but nothing particularly consistent. He also endorsed a relatively recent trauma at work. So, where he was working, was held up at gunpoint, and he ended up sort of like, well, he's held at gunpoint and he handed over merchandise, whatever was being asked of him. And within the evaluation, he sort of presented as like pretty deeply ashamed of the way he acted in that, feeling, I have this quote here, a real man would have fought. It was interesting. It was sort of like I'm above this place of work, but also I should have done something, but also I don't care enough about this place to do anything for it. Um, he reported quite a lot of interpersonal conflict. Some of that was driven by sort of like a grandiose presentation. When I pressed him on kind of like who he wanted to be and who he was, he had a really hard time coming up with something that was realistic or coherent. He talked a big game about like, I should be in like executive positions. People should just kind of, I should be able to walk into a room and people should just kind of recognize my potential and know that I'd be good at these jobs, while at the same time, he doesn't really have a stable employment history or record of achievement that would make him a competitive applicant for those kinds of positions. And I included this quote here. My bosses sometimes fire me because they could tell I was going to get their job. He would talk sometimes about like, I show up to work high sometimes, but I'm really good at my job. And my bosses got mad at me because they knew that like the higher ups were going to promote me. But it wasn't really a coherent story because he was talking about missing work and showing up high. It wasn't a very coherent story. He endorsed a pretty long history of relationship conflict, romantic and otherwise. So he sort of vacillate between like devaluing other people, like nobody will understand me, and nobody understands me because I'm so much better than them. But at times he felt very vulnerable about that. So he'd feel like other people were gonna leave because he did have a history of folks who would hang out with him and then leave him because he was difficult to be around. He did endorse with his wife, and this was true to some degree for other folks as well, but was particularly salient with his wife of a need to be the center of attention. And it wasn't necessarily like he felt a need to be admired per se, but he just felt like if I'm not the center, if I'm not the focus of my wife's attention or really other people's attention, I don't know what I have in this world, was kind of the presentation or the flavor of that. At times it seemed like maybe some of his substance use was driven by like if I'm kind of a mess right now, if I'm really high or really drunk, people are going to have to pay attention to me, was one flavor of some of that presentation. He initially started talking about mood swings in a way that was had a little bit of a bipolar flavor to it, but the more I spoke with him, it became clear it was really more like emotional ability, more like he had like really intense reactions, really short, quick reactions to things, particularly prone to taking offense at perceived slights. He admitted to using suicidal threats to get people to stay, quite literally, like physically with him, as well as just kind of like stay in connection with him. At times, it seemed like it was sort of like an explicit strategy he was using. At other times, it felt like he was perhaps using that strategy without entirely realizing he was doing that. And then, unsurprisingly, he had like pretty profound difficulties with perspective taking and empathy. You know, with his wife, there's a lot of rationalizing surrounding his behavior, but even outside of just his wife, he had a hard time really understanding why other people found him so difficult. And so on some level, he knew that he was part of the problem. On some level, he viewed everybody else as the problem. And he had a kind of a hard time connecting those dots, so to speak. He also endorsed being suspicious of other people and being pretty hypersensitive to perceived slights. This would show up sometimes in when I was talking with him as well. Like I would do like basic reflections, like very simple reflections, sometimes using the exact language that he was using, and it was never correct. Was sort of my experience of working with him. I could never quite capture what he was experiencing. All right, in terms of his record of criminal offenses, most of them are substance abuse related. He has some charges from when he was a kid, as well as convictions. The shoplifting, I think he mentioned like trying to steal like a TV from a Best Buy once. He reported being under the influence of cocaine at the time, and being arrested and convicted for that. His institutional record involves quite a lot of fighting. So he endorsed having problems with staff and other inmates. Definitely a degree of like reactive fighting, some element of proactive fighting. So he'd like feel slighted by other people, wait for them to sort of not be paying attention, then kind of like sucker punch them. Um, he also reported a history of initiating fights as an adult. So he would find like these bars in out of the way places, and he'd pick them because they were out of the way. He could get into fights without anybody reporting him. Basically, he just kind of like the thrill of fighting, so to speak. All right. So from a categorical lens, let's walk through some of the diagnoses here. Let me see if I can maybe. So antisocial PD. Sorry, Jorge, you're the main screen that's being visible, at least on my end. Antisocial PD is certainly one diagnostic category that probably fits him pretty well. Failure to conform to social norms. He's pretty impulsive. That was pretty readily apparent. And then all of these other symptoms also apply to him. He was pretty irritable and pretty reckless in terms of his regard for other people. He also endorsed a history of drunk driving, placing himself and other people in harm's way, as well as cocaine use while driving. Um, I think this is like a relatively easy diagnostic label for him. So you got antisocial PD, borderline personality disorder. There's some elements of this there as well. Um, so it's certainly a history of difficulties maintaining relationships, pretty rocky, pretty stormy. He feels like other people are going to abandon him. On some level, people do abandon him because he is kind of difficult to be around. At times when he was talking about his wife, he'd go from sort of like talking about her as like she was perfect to really devaluing her and talking about her as kind of like the worst person he had met. He did this with some other folks as well. His mom at times too. He would talk in sort of like these, she was so loving. And then when he would talk about sort of her substance use, he'd talk about her pretty negatively. Impulsivity again popping up, sort of a symptom that kind of pops up in the antisocial PD diagnosis as well as the borderline PD diagnosis, and then certainly the recurring suicidal behavior, gestures, or threats. And then he was certainly emotionally labile and had difficulty controlling his anger. His anger got worse, so he'd always had an issue controlling his anger, but particularly after the trauma he recently experienced, that was heightened to some degree. So this was sort of something that was always characteristic of him, but has gotten worse over time in relation to the trauma and is also exacerbated by the substance abuse. So we could potentially put on a borderline PD label for him. Definitely a flavor of narcissism present. He definitely talks down about other people and believes himself to be better and deserving of more recognition and credit than perhaps his achievement history would suggest is appropriate. He's certainly entitled, certainly interpersonally exploitative, and he really struggles to perspective take and think about the ways that his behavior might impact or feel towards other people, or how other people might feel in response to him. He was also kind of narcissistically flavored within the interview, so he would like to value me within the interview as well. Like at the end of the eval, he said something along the lines of like, "I don't think you necessarily know what you're doing, but I appreciate you taking time to meet with me." It sort of felt like he was saying like, "You're welcome for being here," while also kind of devaluing me in that moment too. So we'll certainly put on a narcissistic PD label as well, which I think applies pretty readily. There's some flavor of histrionic PD, and I think you could either bend this as like a histrionic PD symptom. So he certainly endorsed wanting attention above and beyond just like, I want people to admire me. He did talk about just like, I just want attention. I crave attention. I like attention. So you could argue that this is a symptom of histrionic PD. Maybe you might think it's a better way to conceptualize this as part of the narcissistic PD. At the very least, there's some element of attention seeking present in his behavior and his personality presentation. Certainly some elements of paranoid PD. He pretty explicitly endorsed not trusting other people, um, well beyond just sort of like what would be normative considering his relationship history. He had kind of like a persistent belief that other people were out to get him, and certainly had some kind of hypersensitivity to slights as well, which again, the reads hidden demeaning or threatening meanings into benign remarks or events that could arguably be bend with narcissistic PD as well. Uh, so I would say there's some element of paranoid PD present with his presentation as well. All right, from a dimensional lens, from an alternative model lens, uh, we would use what's called one thing we could use is the level of personality functioning scale. So again, if you have a DSM-5, this is like a free scale. It's a clinician rated tool. It's literally just in the back of your book. I use this all the time when I'm training students to think about patient presentation because I basically just ask them to finish their intake if it's therapy or their evaluation and kind of think about the totality of data they've collected. And I find it's a nice kind of organizing tool for them to think about like what kinds of problems this person's experiencing. So this is sort of like my like in terms of the lowest hanging fruit for integration of AMPD into your applied work. This is freely available in the DSM, and I think is a useful training tool. So I would suggest he has like some pretty extreme impairment around identity or self-direction. His sense of self was not particularly coherent. When I asked him about where he wanted to go in life, he would talk about sort of like these grand ideas about the kinds of jobs he should have. But when you pressed him on like, how would you do that? He didn't really have a clear, coherent idea of like how he would do that. I went back and forth on severe versus extreme impairment for empathy and intimacy. He endorsed some degree of like he was aware that he was part of the problem. He definitely felt some degree of bad about some of the ways in which his behavior impact other people, but there was a pretty profound like disconnect there for him in terms of really putting those pieces together. So definitely some pretty notable impairment when it comes to interpersonal functioning. So in terms of the criterion B traits, so this is negative affectivity. This is just lifted straight from the DSM. Again, I kind of want to highlight that, these are probably terms and concepts that you probably to some degree are already familiar with or using in your kind of everyday speech. Maybe you're not as familiar with the particular way that the AMPD operationalizes or conceptualizes these personality constructs, but this is probably not new personality information for you. So in terms of negative affectivity, certainly have high levels in terms of NA as a whole, as well as specific facets within negative affectivity. Pretty low and submissive. He was not submissive at all. Um, yeah, that was pretty apparent in the evaluation and in the police records as well. He was like talking back to law enforcement even when he was sober. Detachment. Um, he's relatively high in suspiciousness, but he does desire some degree of genuine connection with other people. He has a really hard time figuring out how to do that. So he's not disinterested in other people. He's not like exceptionally interested in people. He's not low in detachment, but he's certainly kind of high in suspiciousness. And, especially if you think about doing like therapy with this guy, this is something that you'd probably want to pay attention to if you're doing one-on-one therapy for sure, but also think about placing him in kind of like a group context, that's probably going to show up uh, when he's sharing or disclosing his experiences to other group members. And then pretty low in withdrawal and intimacy avoidance. He wants to be with people. He just doesn't, he has a lot of trouble developing those relationships. Pretty high in antagonism. There wasn't a whole lot of evidence of being deceptive. He wasn't really dishonest per se. He was just pretty mean, pretty grandiose, really wanted attention, and had a um, really had a hard time not being exploitative of other people around him, even if he at times sort of was aware that maybe he shouldn't be doing that. Pretty high in disinhibition across the board. I mean, maybe even high in irresponsibility as well. But certainly an impulsive guy, certainly willing to place himself in harm's way. The driving under the influence, as well as kind of the willingness to like find remote bars to get into fights with people, is also like pretty dangerous. And then he was pretty average in terms of psychoticism. He was not particularly odd or eccentric in presentation. He wasn't low in that either. He was kind of typical levels of this. All right. So in terms of thinking about this guy, so I think about his personality functioning as being particularly sensitive to sort of interactions he has with other people in environmental contexts. So, his personality functioning became particularly pronounced when I was evaluating him. So when he felt vulnerable, he would oftentimes be mean or antagonistic in some capacity. And so when he felt like I was pressing a little bit too close to home, the impairment would kind of pop up as more severe, more notable. Um, uh, and then the flavor of that presentation, the flavor of that interpersonal impairment was typically sort of more antagonism and grandiosity. So he would kind of use his grandiosity to kind of regulate the vacillations in his personality functioning. I would say that the personality functioning, substance use, and aggression are kind of this really nasty feedback loop for him. They're all kind of interconnected to each other. So the worse his personality functioning, he's more likely to use substances and vice versa. The more substances he's using, the more likely he's going to devolve in terms of his personality functioning. And both of those things are certainly going to place him at heightened risk for perpetrating violence in more the near future, so to speak. I'd also think about high negative affectivity, antagonism, and disinhibition as things you want to think about in terms of like treatment and risk monitoring and management. So in some ways, his suspiciousness and grandiosity serve him. So in a sense, he has been burnt by other people in the past, and so this sort of personality configuration is able to keep people at a distance, so to speak. But it's kind of doing this push-pull for him where he wants to be connected to other people, but because he's like this interpersonally, because he presents like this, other people don't really want to stay in contact with him. And even the friend group he had in high school, he reported that they would regularly have kind of like friend breakups, so to speak, and getting back together. And then callousness, manipulativeness, and grandiosity as barriers to accountability. That's something that's probably going to pop up whenever you do any sort of like challenging of his cognitions or challenging the way that he's rationalizing some of the behavior or patterns that you're targeting in therapy. Todd has some strengths. Detachment is mostly average. He does it. It would probably be worse for him if his detachment was really high. So if he was like really antagonistic, really impulsive, but also wasn't really interested in other people, he'd probably be particularly scarier to interact with or scarier to deal with. And certainly in some capacity in the evaluation, he expressed an interest in being with other people. And so, arguably that could be something that you could challenge or think about in terms of leveraging with respect to interventions and risk management. So in terms of some big takeaways here, I found over the years that this is like not, this model feels weighty at first when you start working with it just because of all the terms and it's kind of a new way of thinking about people. I've kind of compared it before to sort of like if you're going to a friend's house and they have a board game that they're trying to teach you how to play and they say basically like let's do one or two practice rounds and then you'll get it. It's kind of like that. After you use it a few times, it feels much more intuitive than perhaps it feels when you initially start thinking about applying it. And the research is pretty clear that it's relatively easy to learn. It's not something that's overly challenging or overly complex for trainees. I think the AMPD provides a much more parsimonious, kind of clearer case conceptualization picture than the categorical model offers. We slapped on a few different diagnostic labels, identified some symptoms that may have been in one PD category, but may have also been better conceptualized as another PD category. I think the AMPD just does sort of a fundamentally better job of capturing kind of complex patient presentation. Uh, I'll also just say this, and I've been ending talks with some version of this point, which is that like this is just happening. At this stage, personality scientists, we have stopped studying categorical diagnoses in and of themselves per se. We have increasingly shifted to studying unified dimensional models of personality disorders, and that is something that's also happening at a broader level, even outside of the PD world. Clinical psychologists, at least, have largely shifted towards thinking about people from a dimensional lens in terms of their personality as well as their psychopathology presentation. And some recent guidelines that came out, I have that right article cited, suggest that sort of like evidence-based approaches to psychological assessment should incorporate both categorical and dimensional approaches to thinking about people. There is a small, growing, but not large enough body of research on applying the alternative model to forensic and correctional populations. Uh, This is a much smaller body of literature compared to the broader literature in terms of the AMPD. It's getting better, but there's certainly some pretty notable gaps that we have right now. So, for example, like there's not really data on like inter-rater reliability of interview-based assessment of personality pathology using like AMPD instruments. So, like the PCLR, people have problems with that measure with that model of psychopathy, but at the very least, we have a lot of data talking about kind of strengths and weaknesses of that measure, and a lot more data for us to carefully consider how to implement that instrument within our practice. We don't really have that same level of body of research with the AMPD in these particular populations. I would say my takeaways here is that, I think the AMPD is probably pretty ready or okay to use if you're doing like more therapy oriented work. I would probably not use this as the main model that I was using in like forensic assessment work. It certainly could be useful as like a supplemental case conceptualization approach. But there's certainly some problems to be worked out with applying this model to forensic assessment types of questions. So for example, I kind of think about like the tension between in forensic referrals, we're supposed to assess sort of like very narrowly like what is specifically related to the referral question. But the AMPD is this large kind of comprehensive model where it's unlikely that all of those elements of that model are directly relevant to the particular referral question. And then one of my final points here is if you're using broadband personality instruments like the MMPI-3 or the PAI, you are actually already assessing the alternative model. You may just not know you're doing that. So the MMPI-3 has those Psi-5 scales. The RF also has this as well. It doesn't provide like the comprehensive coverage of the AMPD that you find in the PAI, but there's a larger body of research on the MMPI-3 and prior versions and in terms of the Psi-5 scales in forensic and correctional populations. And then there's kind of a growing but pretty small and comparatively small body of research using the PAI to assess the alternative model. So the MMPI-3 is going to give you coverage of the criterion B domains. There's more research behind them in these populations. The PAI is going to give you more comprehensive coverage of these constructs, but there's less research in forensic and correctional populations. So if you're already using these kinds of instruments, you're already kind of doing this work. And then I've highlighted a few articles, or two articles in a book. In terms of like training students. I use that Bach article all the time. I really like it a lot. It walks you through 6 different cases and how to think about those cases with the AMPD and categorical approaches. I find it to be like a pretty trainee-friendly article. This book is also quite excellent. Jamie Anderson, who's a colleague of mine from Sam Houston, and then Nicole Schumacher, who's a doctoral student. We just published this sort of like how-to guide if you're somebody who's not as familiar with the AMPD but would like to start incorporating this model into your training of uh, trainees. This is a good kind of jumping off point if this is not your particular area. All right, well, thank you for sitting here and happy to answer any questions you have or talk with you about this model.
Dr. Ruchensky, thank you. Appreciate your time and sharing your expertise. Um, I know this isn't necessarily your area on from a day to day or with clients, but any thoughts on the AMPD and how it might apply or any drawbacks with adolescents, especially later adolescents?
So I would say, I'm not really like a child or adolescent psychologist. I would say one of the things that I find to be a strong point for the AMPD is you can take a bit more of a strengths-based approach. The categorical model is like an explicitly deficit focused model. You have this symptom or you don't. Whereas because the AMPD is dimensional, you can sort of highlight some personality presentation that might bode well in terms of prognosis. So, in terms of working with adolescents and children, I think there's some real value there in terms of how you can frame some of your personality findings in a way that potentially reduces some of the stigma attached to. I mean, PDs are pretty stigmatizing, so I think that's probably the main, at least for me, at least that's what comes to mind for me in terms of some applications for adolescents and children.
Thanks.
Hello? I think I've unmuted myself. A little bit difficult to join from my phone. Okay, good. Um, I had the comment there. I'm really glad you gave this talk. I've been really curious about the AMPD, but it was always a little overwhelming when I was trying to read through it, and I appreciated the case and the way you broke it down. This might also be a little bit outside the sort of the realm of what you were talking about or interested in, but I was wondering if you knew anything about bringing this kind of this sort of model of looking at these underlying maybe neurobehavioral functions to the rest of the DSM, rather than confining it to the personality disorders of it.
When you say like
Yeah, just curious.
when you say neurobiological functions,
Well,
what do you mean by that?
sorry, neurobehavioral, sort of emotional functioning, avoidance, antagonism, that kind of thing.
I know this is a small body of research. I know there's some research doing like some like EEG physio research that's linking these traits and presentations to certain like event-related potentials. I don't think of like papers off the top of my head. Um, but I know there's sort of some degree of growing interest in the physio world with these, with the AMPD. I don't think there's like a particularly robust body of research though that would more cleanly kind of like link these traits to sort of like neurobehavioral presentations or constructs.
All right, if we don't have any other questions for today, again, thank you, Dr. Ruchensky, for coming on here and presenting for us today. We appreciate your time and effort. But I will go ahead and throw up the QR code. And again, thank you, Dr. Ruchensky, for presenting.
Thanks for having me. I really appreciated being here.
There's some commentary in the chat. Sounds like some appreciation of thinking of the spectra versus categories.
I'm glad it was helpful. I appreciate that.
Yeah,
Yeah, genuinely, I feel like this is the kind of model that once you just start using it, it becomes pretty intuitive. It's scarier than it seems.
I think I would agree that it's in our everyday language. Like, oh, this person's a little this, a little that. They're kind of shy, but not that shy. They're kind of, this, but not completely. So,
Yeah, I find clinicians are already kind of talking in AMPD language, even if they're not using the model explicitly. I think most of us kind of intuitively think about people this way.
yeah. All right. Well, I think people are signing off. So thank you, Dr. Ruchensky, once again on behalf of the department. I appreciate you taking time to share this expertise and present us some new information that we're not accustomed to hearing about. Like I said, with this dimensional thinking about personality disorders and personality traits and things.
Thanks again for having me, and hope you have a good rest of your weekend.